All right, so the title today is Embedded Proactive Consultation-Liaison Psychiatry, What We've Learned and Where We're Headed. Okay, so the last time I did grand rounds a few years ago, I spent nearly all the time telling the FIPS origin story, how we got started, how we expanded to a second team, and the results of our first paper looking at the program. I'm pretty amazed how things have changed since then. There are now dozens of publications that are out there about proactive psychiatry. And it's now being practiced in a lot of different, very diverse settings across the U.S. and even worldwide at this point. There's a very active and growing special interest group at the Academy of Consultation-Liaison Psychiatry, and we continue to get queries and site visits from hospitals. We just had a local community hospital here a couple of weeks ago trying to see if they could learn what's the special sauce. How do we import this to our hospital? So we're getting a lot of good interest. So with that, I'm going to spend a lot less time on our origins, but instead give kind of a limited overview. I'm happy to circle back if people have questions, but then move on to more recent findings, including the recently published results of the much anticipated home study, which has been very interesting. Okay, so this is us, the FIPS team. So FIPS stands for Proactive Hospital-Based Intervention to Provide Psychiatric Services. There are two teams, each composed of a half-time physician, full-time psychiatric nurse practitioner, and a full-time psychiatric social worker. I think they're all here today, sitting up front. And so the first team started in 2016. The second team was rolled out in April 2017. And we currently cover 8 units in the Department of Medicine. And all of this, really the true origin is from a program that was started at Yale. There was a site visit to Yale University by basically their state auditors in response to a non-psychiatric complaint. This is what always seems to happen. And as part of that, they said, okay, these other findings, whatever, but your psych consult program stinks, fix it. So William Sledge, the guy in the upper right, sat himself down and said, okay, well, what would the ideal consult program look like? And his first thought was, well, I'd like to know right when they walk in the door that they're going to need a psychiatric consult. So that was sort of the actual origin story of proactive psychiatry. They started a pilot, really, to screen all the admissions to the medicine floors. And studied it and found early on a pretty impressive impact on length of stay. So there was a 0.64 days length of stay. Clinically doesn't mean a whole lot. From a financial and a patient flow standpoint, it was enormous. And the program is still around today, but it was a very compelling reason for the proactive program up there to continue to operate and to grow. Oh, I'm sorry, did mention Ben Lee. Ben Lee's there too. He was also part of the origin story, helped implement the proactive program there, and also he's now the chairman at Rochester, where they also have proactive psychiatry. So very briefly about where we practice. So Maryland is a Medicare waiver state, which is an all-payer system. That means that the Health Services Cost Review Commission sets rates for all payers operating in the state, including Medicare and Medicaid. It's been around since the disco era. And they do bundled payments and global budgets. This is a big change it's a huge change from the traditional fee-for-service model, and it has implications for what we do and how we do it. And part of that is that we have to focus a lot on financial metrics. So length of stay in the early days of this was probably the most compelling thing that we could look at. I'm going to talk about ways in which we may be moving on to other domains to try to capture with data what we're seeing clinically. The psychiatry consultation really has not been able to show itself as profitable or even as a break-even proposition within the traditional fee-for-service environment. So again, other things that we look at, staff retention. If you can show an impact there, the financial implications of that are huge. Most often, you're talking about a cost offset. If you can bring in some money to offset your cost, that's considered a favorable thing for a needed service. I'll talk a little bit about observer cost, and I'm hopeful for the long run that by kind of taking this mindset and this approach that we're anticipating what's going to be bigger changes in reimbursement models. And we've been hearing for years from CMS that they do want to move away from fee-for-service toward bundled payments, population health, that are linked to quality and safety outcomes. So these are the data from our first paper, and again, it showed a length of stay savings. Brian Bronson at Stony Brook ended up writing a very good paper, I'll talk about on the next slide, about the impact of length of stay savings. So here, shorter length of stay when compared to similar units at the exact same time, but also shorter length of stay when compared to the exact same units the year before. We also had a shorter time to consults, meaning that latency between a patient arriving and being seen, and that was true for both comparisons. And we did not make an impact on 30-day readmissions, but there were some pretty interesting findings on inpatient psychiatry that I'm going to talk about. So this is our sort of back of the envelope calculation. The cost savings, so a night in the hospital back then was about $2,000. This is a relatively limited study. It was about 311 patients. You multiply that by the dollar amount times the number of days saved compared to, this is the head-to-head real-time analysis, and it's about $943,000 in saved money for a program that cost about half that. So we thought that looked pretty good. And then when you look at the pre and post, the savings are even more pronounced. So it's a little over $1 million, again, for a program that cost about $477,000. So Brian Bronson at Stony Brook wrote a very good paper about this with more detailed return on investment assessment that showed at their setting that also their program more than paid for itself. This model is not as sophisticated, obviously, but it shows the length of stay that was linked to the model, not just covered, but nearly doubled the amount of money it cost. So all of it seemed good. But again, this is an interesting setting that we're practicing, and we still have to show what we're doing. It's not enough just to parade that, to show people that slide. And we wanted to capture how we actually make the donuts. That's the picture. So we have this embedded in all of our notes. It's a pull-down menu that has a flag on the backside that kind of feeds to a Tableau dashboard. And for whatever intervention or interventions we're performing, we just click on the box and it feeds to the Tableau dashboard, and we get this very cool, almost real-time data on what we're doing. So this is an example of one of the frames in the dashboard. This is 3 years worth. I took the last 3 fiscal years that would have ended in June of this year, just to show sort of a sampling of the volume of work that we're doing. And as you can see, it's kind of a huge number. It's nearly 18,000 patient contacts in 3 years. It's about 6,000 a year. Over 6,300 admissions and 4,700 individual patients. And it's averaging about 3 touches per admission per patient. This is clearly not a one-and-done model. We're seeing the patients serially, and Ms. Johnson was a good example of that. So I've shown this slide before, but this is the staff satisfaction models. It's color-coded so you can see it from the back of the room. Red is bad, green is good. We went from very bad to very good. So staff was very happy with what we were doing. I'm going to use this slide until the color bleeds off of it. Nursing turnover has been a tricky one. So this is a kind of a schematic of pre and post FIPS nursing data. At the end of the day, they're about the same. Unfortunately, there's no real impact on the FIPS floors versus the other ones. The top picture, the yellow up there, you can see us sort of creeping in and taking over. I'm sorry, the green is where we were taking over. So by the end of it, we were covering all 8 of those units. But again, the numbers are pretty similar. I've looked at it 10 ways to Sunday and haven't seen a pattern there. But there was a study from Mark Oldham and the gang at Rochester that seemed to have different findings. The overall trends, I mean, for us were worse, and I think the pandemic played a big role in it. But Mark's program thought they saw a possible impact, particularly on questions of why nurses were leaving, and it was concerns about population, and it was implied there that perhaps having too many psychiatric patients that were untreated or undertreated on their units was a factor. It didn't look like it was statistically significant, but they called it favorable trends in nursing retention. So it's encouraging, but I do think it merits further study. Observer use, I'm almost ashamed to put this up here because the quality of the data are so bad, but this is about 6 months of impact on on observer use. And if you look at the comparator units, the trend line is pretty much flat. If you look at the FIPS on the right, the trend line is down. So it looks like we made a big impact. It went from 2,600 to about 800 hours per month of observer use on those units. But I think this was not publishable. This was, I think this was just observer use. It didn't account for security. It didn't account for nurses having to sit observer stations. So this would not pass muster for publication. And the other thing too, this is a tough metric, especially if you want to keep it going, because once you made your impact, it's tough to keep making impact. The best you can do at some point, I think, is just kind of maintain your gains. So maybe more to come here. So I'm going to pivot a little bit and talk about more recent studies, and particularly our focus on some race and demographics that we've been looking at more closely. So at this point, we've done several studies looking at our experience with FIPS and with that of comparing it to the traditional model. Our first study focused on length of stay and staff satisfaction. I've shown all that, had good results. We're very happy with it. One thing that kind of a curious finding, and we couldn't explain it at the time on the first paper, was we saw significant racial differences in that the FIPS programs were more likely to see black patients. And it was one of those things that sort of stood out and couldn't put it in context or explain it. In the second study that was led by Joe Bienvenu, instead of just a handful of units in medicine, he looked at the whole hospital, and this is actually Paul Nestat's data initially, I think. And he found the medicine floors that the FIPS program operated on at 3 days longer length of stay than the rest of the hospital. So that's all comers, which is in itself kind of interesting. Something about the patients on those particular medicine floors. But he also found that the patients in psychiatry, seen by psychiatry in the rest of the hospital, stayed 13 days longer than average, which I think is pretty remarkable. He also found the FIPS floors were more likely to admit to psychiatry, and we've found that in all 3 studies at this point. And the consultation rate for the FIPS floors was about 25%, so nearly a quarter of the patients were seen by FIPS, compared to 3.7% in the rest of the hospital. And then finally, he found the traditional model saw patients who were more likely white and privately insured, but also younger and female. So these are data that I presented at ACLP at the last meeting last year. And it's from our most recent study, which was published earlier this year. And again, was a look at the whole hospital. For these last 2 studies, we lost our apples to apples comparison, as we're looking not just at general medical floors, but the whole hospital. And at least the adult side, PEDS is not part of this, but we looked at it included the ICU, surgery, OB-GYN, oncology, everybody, and the medical floors that we weren't covering in surgery. So the study period was 2017 to 2021, and at that point we had 2 proactive embedded teams, and it was compared to the GHP team, the traditional model. The proactive service saw over 4 times as many patients. It was 7,600 versus about 1,800 on a much smaller footprint. A smaller proportion of the proactive patients involved transfers or admissions to surgery or the ICU. We'll describe that a little bit more on this slide. So again, we found the proactive model was associated with shorter time to consult, shorter length of stay. And we found too that the work of the 2 models overlapped and was complementary. There were a fair number of co-managed patients who bounced between the floors. They might start in the MICU, for example, and then step down to a general medical floor, then might need surgery and so on. Those, again, as you can imagine, those tend to be the most complicated patients, and they had longer hospitalizations. But in general, GHP saw sicker patients. They were more likely to require the ICU and or surgical teams, and largely because they were only service covering them, but not exclusively. The proactive consultation chart review, we thought, might provide more case finding and care for patients with acute psych needs. I'll talk about that in a little bit on the next slide. But finally, we thought that the early data suggested the proactive screening might yield a consultation census that's more consistent with kind of the core admission, racial, and socioeconomic demographics because of the higher volume that we were seeing. So if you see a higher volume of all the patients, you would think it would seem that the demographics would be more in line with the demographics of all the patients that come to the floor. And this is really what we're looking for in the new data that I'm about to show. So I mentioned the issue of case finding. We seem to see significantly increased case finding of patients needing psychiatric care on the FIPS team. So I posted here data from the third study showing that the FIPS services transferred 3 times as many patients as GHP, which GHP covers a much bigger footprint. So again, that's about 4 times. It has about 4 times as many beds that they cover. So this is 3 times the admissions coming from 1/4 of the beds. Another way to think of this would be admissions per bed. So the 111 admissions came from about 630 beds, and the FIPS admissions was 334 admissions from 175 beds. So those are ratios of 0.18 versus 1.9. So it's 10 times the rate per bed, which is kind of interesting. Now, admittedly, a lot of transfer to psychiatry do come from the Department of Medicine, but this is a large increase from our historical patterns. The demographic patterns for the FIPS consults seen, again, showed patients were more likely to be Black with public insurance, but this time were more likely female. I will mention our latest data comparing the sex differences and overall floor demographics haven't revealed anything significant at this point. We're having to recode some insurance stuff on the non-consult admissions, which is taking some time. But I think this is something I think we need to look a little more closely at, and that's the actual transfers. We looked at this after the first paper, the patients that were transferred to psychiatry from medicine. What happens to them if you're trying to show that you're doing the right thing? And these are relative, compared to what I'm going to show you in a few minutes, this is relatively smaller numbers of patients. It's in the hundreds. And there were about 1,800 patients followed that year. And these are all the patients that either GHP or FIPS transferred to psychiatry. So there were a total of 88 patients that year that went to Hopkins Psychiatry from medicine. None of them were readmitted within 30 days. That's a pretty good number. There were 16 patients that were admitted outside hospitals, either because of capacity or insurance issues. And of those, 6 1/4 were readmitted within 30 days, which is very low, especially when you consider the average medicine readmission rate was 18% at the time. So there's something, I think there's something here. This is something we should be looking at, I think, with the bigger data sets that we're looking at as well, particularly if we're caring about the longer term impact of what we're doing with patients. Okay, so I'm going to talk about the home study. This was conducted by Michael Sharp and Jane Walker, who are the dynamic duo from Oxford. They visited us here last year. This is believed to be, I think this might actually be true, the largest randomized controlled study in the history of consult-liaison psychiatry, and comparing a form of proactive psychiatric consultation versus usual care. It was many years in the making, just recently been published in Lancet Psychiatry. So it was conducted over 3 sites, about 3,600 patients, all of whom were over 65 years old. Enrollment was stopped early due to COVID, but this was actually their target. They were trying to take care of the patients that they felt stayed the longest in the hospital, which were the geriatric age patients. So they were all over 65. The primary outcome was length of stay. Secondary outcomes were quality of life, independent functioning, some mood and anxiety measures. They had cognitive functioning, experience of the hospital stay. This is actually the first attempt at getting some kind of patient or family experience data with the proactive approach. The intervention itself, though, was somewhat limited. It was advice, not co-management, in the way that a lot of what we do is more really kind of trends into co-management. But they did have occupational therapy on their teams, and there was a CL fellow who played a role as a care manager, so it was not fully hands-off or the one-and-done model. They did not show statistically significant impact on length of stay. If you dig around in the data, there's an appendix to the study. If you get in there and look, there's one site that threw them off, and it's Exeter. Oxford and Cambridge, the numbers were, well, I think one of them was over a day and one was just below a day, but Exeter was a wash and pulled them down. And we had a very interesting phone call with Michael and Jane a few weeks ago, and they were talking about some of the cultural issues. They didn't say Exeter in particular, but some of the cultural issues they had with certain caregivers who just didn't want to let the patients go. Maybe a more generous way of saying this is they wanted the disposition to be perfect when they left the hospital, but they ran into this culture of we're not going to discharge the patient, which probably hampered any effect that what they were doing was going to have. Anyway, kind of interesting. They did find that the program was cost effective, and there was, what I found really interesting, there was an impact on 1 year survival. So that, you can, oh geez, you can't even see that from the third row. So there is a survival, it's literally a survival curve in the bottom right-hand corner. And even I can't see it, standing 10 feet away, but I'm old. But the lines separate. And the proactive intervention, they lived longer somehow. Then came COVID, and everything kind of stopped. But it was a very interesting thing that they did, maybe there was an impact there on survival. But again, COVID stopped everything. It certainly merits further study. So at first glance, it looks like, well, this was a failed study in terms of its primary outcome of length of stay. But there were, and this is what we ended up publishing about in the Journal of the ACLP and Lancet Psychiatry recently. There were pretty significant differences between the home study program and proactive embedded CL as it's generally practiced, especially here in the US. First, there was no screening. Patients were randomized, and then the psychiatrist would go see the patient to see if they needed an intervention, it's very different from what we do. Also, the patients were recruited at a mean of 3.5 days into the admission. And I think I've mentioned before that part of our early impact was getting to the patient early. They've already lost 3.5 days by the time they're seeing the patient the first time. So I think that probably had a pretty large impact. Any patients with prior psychiatric consultation during their hospitalization were excluded, or if it happened before they were recruited to the study, right? So any time in that 3.5 day period, that's a pretty long delay. You're excluding the patients who for us would be the ones we're most likely to see. That's kind of our bread and butter. It's kind of surprising that those patients were essentially removed from the study. There's no unit level integration in the way that they're not really embedded. And some other ones that were kind of huge. Mean age of 82. This is decades older than the average population of a lot of the studies that you'll see here in the US. They also had a mean MoCA of 13. Dave can attest to this. That's kind of low. That is moderate dementia, and it points to a population that is pretty impaired. And again, back to this idea of you're trying to make an impact with some of these longest stay patients. When your mean MoCA is 82, that would seem to suggest that those factors that you might alter while they're in the hospital might help a little bit, but you're going to be highly dependent on factors outside the hospital to get them out. They're going to have to go to some kind of structured setting. If they're going to a home, they're going to need all kinds of supports to stay there. So I think that probably was pretty significant. And last, there's no data on psych transfers. It didn't look like any of the patients were transferred to inpatient psychiatry, and it could be that those are the ones that got the psych consults and it just moved earlier. So the study was designed, again, to try to show an impact. They were aiming for a full day, and they didn't achieve this, but there was a statistically insignificant difference of about a half a day, so 0.45 days, which if it was true, would be significant and impactful. There was a higher daily discharge rate that was statistically significant. The rate of discharge was 8.5% higher on the intervention units, and it was more notable in the long stay patients. And there was some cost advantages too. And again, I mentioned the lower mortality rate, so the relative risk was 0.88 compared to the non-intervention floors. So I'm going to switch back over to this issue of racial differences in consultation. This is something that we've been curious about, again, all the way back to our first studies. We know that there's a literature on disparities in mental health, service use, access to treatment, use of restraints even. But this topic of disparities in inpatient consultation really hasn't been extensively studied. There was one study at Hopkins I'm going to mention on this slide. So this is a paper that was published in 2020 by Matt Stewart, who's an ENT surgeon, and Ross Stewart, a peds internist extraordinaire here at Hopkins, and a couple of other folks. They took a convenience sample with the first 2,000 adult patients admitted here to Hopkins during the study period. They didn't find any statistically significant relation between race and the type of inpatient consultation that was received. There was no statistically significant difference in the number of inpatient consults found either. Their conclusion was that though implicit racial bias may be a factor, or may not be a factor rather, in ordering consultation, the findings are more likely affected by more appropriate factors such as the patient's age, length of stay, and complexity or severity of illness. And so these are all consults, not just psychiatry, and we can't tell how many psychiatry consults there are. It's 2020, it's conceivable it's a very, very low number, if any. But this is all very interesting and maybe reassuring in its way, but still leaves some unanswered questions. So as a psychiatrist, I'm interested in this idea of implicit bias, particularly among healthcare workers. We wrestle with these questions in our fields at times that involve assumptions about what we observe and how do we turn these into testable, observable questions. We had noticed, again, I'd mentioned this, there were patterns in the consultation requests and demographic differences in psychiatric consultation, at least here at Hopkins, that we thought needed further exploration. So as we were doing this, a very interesting paper came out earlier this year from Mass General and Harvard Medical School that was published in General Hospital Psychiatry. So this is a quote from the conclusions. Black identifying patients may be more likely to receive psychiatric consultation and be placed on legal holds because of a combination of chronic adverse social determinants of health and race-based bias. Conversely, Latinx patients may be less likely to receive psychiatric consultation because of language barriers and other factors. They didn't really test that idea. The lack of disparities identified in other domains may be encouraging, but larger studies are needed. Further research is also needed to identify causality and intervention that could help close the gap in care and outcomes for racial and ethnic minorities. So this is saying that Black and African American identifying patients are more likely to get a psychiatric consultation at Mass General. And this is very interesting and almost seems counterintuitive. When we think about consultation patterns, and at least when I think about it, and worrying about social determinants of health and disparities, I usually think the opposite. That racial and ethnic minorities would be less likely to get a consult. The disparities in access would mean fewer consults. So again, we're thinking in terms of access, but they seem to be seeing and saying something very different. In fact, they may be suggesting something a bit worse. It's that second point that Black and African American patients may be more likely to be placed on legal holds because of a combination of chronic adverse social determinants of health and race-based bias. The authors say early on, by way of background, that it's a study to explore structural and institutional racism and impacts on healthcare disparities, which is very important and does need to be examined and explained and fixed. Describing the racial patterns alone, however, may not get to the true causes, and I'm a little wary of conclusions based on untested hypotheses. It's the old problem in research. Correlation does not necessarily mean causation. But also brings up a separate but interesting question. Is getting a psychiatry consult a good thing, meaning is when a disadvantaged population don't get them, is that a marker of disparity, or is it a negative, meaning that these psychiatric consults are being disproportionately imposed on the disadvantaged? So indulge me a little bit. So I won't do the full rant, but seeing psychiatry consults as the latter, as a negative, taps into some old ideas about psychiatry, espoused by Foucault and others, Sass, that psychiatry is not an actual field of medicine, it's merely a form of social control of the other or the different. I'm oversimplifying Foucault, no doubt, and conflating quite a bit here. But those assumptions that line up with that type of thinking had a very adverse impact on psychiatry during that era, and it was during deinstitutionalization, which may have been a very needed thing, but speaking in absolutes did play a role in how the whole system of care was dismantled and very little substance left in its place. But again, this idea that psychiatry is at its core a mechanism for social control or punishment is, for anyone who works in that setting, difficult to accept or believe, but still, it's something that they seem to be suggesting. I do agree with the authors that it's possible this pattern is a reflection of something else or some combination of factors, including disproportionate access and resources to psychiatric care, fractured or non-existent supports, perils of living in blighted neighborhoods, and so on. But these questions remain untested and unanswered. So what about Hopkins? We noticed that, again, these racial and socioeconomic differences between proactive and traditional model, where FIPS were seeing patients who were more likely to be black and older and on public insurance on very similar general medical floors. We may have gotten an early clue from our first study, which was this one, that with that pre and post comparison on the exact same 3 units, we didn't find any race or sex differences. Only the differences in insurance remained. So, what does this all mean? The proactive screening is at some level race blind, in that it's not a factor, and our teams certainly would screen for, and race is rarely mentioned in the clinical notes. It might be presumed by elements in the notes and read during the screening, but those suppositions are often wrong. The proactive model is different from the traditional model, and that no one from FIPS has actually seen the patient, which is part of the process of the traditional consult model, which in theory could be a conduit for implicit bias in the people that are asking for the consult. So I will admit that a part of me hoped that FIPS, because we see such a high volume of patients, maybe there was some impact there, and maybe some magical implicit bias defeating way we were getting at disparities. But there was still one question we really haven't answered yet. Do these actually represent differences in detection of need for a consult by the 2 models, or does seeing a higher volume mean getting closer to the core demographics for all patients on the floor? So to answer these, we need to compare all the patients seen by the psychiatry teams and all the patients admitted to the same floors during the same time period. So it's possible these differences are just demographic differences between the units and nothing to do with psychiatric consultation at all. Pat Carroll's probably not here, but it's the race differences. So the FIPS floors, the proactive floors, the proactive team saw 51% were African American, 43% on the reactive team. FIPS 42% white versus 53% white on GHP, and it was statistically significant. So, and this was, all 3 studies actually had very similar findings. Yes. Yeah, sorry, it's not. I need to blow that up. So these data are not completely, they're not ready for peer review yet. Hang on, make sure I can see these. Are those visible? Okay. Okay, so these are not, again, not ready for peer review, but just to give a sense of what we're finding. So the demographics and clinical variables that we've collected here are from nearly 10,000 psychiatric consults over 4 years and a total of nearly 134,000 inpatient admissions to all the floors. As you can see on the panel on the right, there are racial differences between the floors at baseline. So the GHP floors were nearly 70% white, around 30% black, and FIPS floors, 56% black, 44% white. Those are big differences. So the preliminary data seem to suggest that FIPS, which sees a higher volume of patients, sees a racial mix that's very similar to all the patients that are admitted to those floors, with no significant differences from the overall unit demographic. So that was the big question we wanted answered. And GHP, this is interesting, may be more likely to see black patients on floors that are predominantly white. The patients that are managed by both teams, the ones that the complicated ones that kind of bounce around more, see a racial mix that's somewhere between the 2 models. And we're still working on the insurance numbers. We need to clean that up, but we're still working on it. So looking at these consultation patterns, there may be an indication we found something very similar to what Mass General found. And the GHP, via the traditional model, was a little more likely to be asked to see black patients on mostly white units. In fact, our early numbers looking at this in our published paper suggested something similar. The traditional model in that study, too, was more likely to see black patients on predominantly non-black floors. So for FIPS, the consult pattern is close to our unit floor demographics, and maybe slightly less likely to see black patients than the floor demographics. But this is like a 1% difference on the floors, with a much higher volume of patients with black patients. And seeing a higher volume does seem to get us closer to the floor demographics. And it makes you wonder, is there some sort of saturation point? We're seeing such a high percentage of the patients that any of those differences kind of gets obliterated, regardless of what's causing it to begin with. There's a bigger question of, well, what's a normal admission pattern for this hospital? I cannot answer that. We're a large academic medical center with an international draw in a city that's roughly 60% black, in a neighborhood that's nearly 80% black. So determining from all that what is a normal distribution, that's a tough one. But anyway, so the other earlier stuff is kind of interesting. So just to sum up, the things that have been replicated many times about proactive CL, length of stay and discharge rate, staff satisfaction has been replicated, cost savings, generalizability has been shown many times, and case finding. Places that are still kind of works in progress or mixed results are patient satisfaction, mortality, nursing retention, readmissions, healthcare quality of life, and overall quality of life. Those last two were in the home study and actually were significant improvements. So I think that we need to be looking more closely at that. What's next? I think it's time to move on from length of stay. It's been shown many times, and I think we need to get at more of these. What's the quality? What are we actually bringing with this particular service? We need further work on racial and socioeconomic disparities. I think we need to shift to greater work on subpopulations. The home study was geriatric. I think there's room for other populations to look at, including specific disorders. We really want to look at mortality and more patient satisfaction. Automated screening, I'm not going to say AI, I just said AI. At some point, kills me a little bit. I think we're going to have to move from screening by hand to something more automated. And we are still very much engaged with ACLP. The proactive SIG is big and growing. It's wonderful. And there are multiple presentations on proactive CL in Miami in a few weeks. I hope some folks will be able to come see us. That's it. Thank you.
Thank you. Very, very interesting. Pat, let me start by asking you, you talked about the home study in the UK and the geriatric population and the low MoCA scores, which makes me think, have you found that there's a particular type of patient or type of problem or clinical scenario or set of them where you tend to be especially effective? And conversely, are there types of clinical scenarios where you don't feel like you can help so much?
Yeah, that's a really good question. I think the ones, I think we've done a good job at detecting patients who need more intensive psychiatric care, either by us or it puts us in a role of being a conduit to then getting inpatient psychiatric care. So we've had, within the last year or two, we've just had a cluster of folks that completed essentially a full course of ECT on medicine before going home. So I just get that feeling that we're very much embedded. It's kind of great that the medicine teams can see how powerful the treatment is and how well it works for the right patients. So I think those are kind of success areas. The ones where I think we still struggle are the frequent readmissions. And some of that, as you can imagine, substance use is sometimes part of that picture. Sometimes it's psychiatric, but often it's their medical care. And that's one that it's tough for us to say, well, if we treat their psychiatric condition a little better, maybe they'll be more adherent with their meds. We're just not kind of finding that to be the case. So that, putting a dent in overall unit readmissions, it seems to be really challenging.
I want to let other people have, I'm tempted to ask a follow-up, but I'll keep going. Dr. Kolika.
Thank you. Thank you for the talk and the work you're doing. I'm sure that patient satisfaction and family satisfaction will be positive. My question was related to the readmission. You noticed that those that get transferred to psychiatry don't get readmitted within 30 days. I'm wondering, is that from discharge from medicine, and does that account for some of the longer lengths of stay that we see sometimes on site?
Yeah, you should be a hospital administrator. That was the first question they asked me. Actually, it was more snarky. It's because you keep your patients too long in psychiatry, is what I was told. No, it's from admission. I don't think we got dinged on those patients either. I'd have to go back to absolutely be sure, but our readmission rate is much lower than the Department of Medicine's is, and that's been true for a long time. And this was 2016, 2017 data. Anyway, I think it would be interesting to see if we are actually making an impact with these folks that are going over to us in terms of their 30-day readmission from psychiatry. But nonetheless, I could parade this in front of them and at least tell them there were no readmissions for the Department of Medicine to get penalized by.
Mm-hmm. Okay, Dr. Gilbert.
I was hoping you might talk a little bit about the role of addiction of psychiatric trainees or internalizing trainees. How do we train more people to do this kind of work?
Do we have residents here? No, that would be my dream to have this as part of resident training. We've been slowly not slowly, it's actually been pretty rapid. We now have geriatric psychiatry fellows that rotate with us. And this year, thank goodness, it's the first year that we have CL fellows, Hopkins CL fellows rotating with us. It's great. We love it. I would love to be able to make it part of the PGY3 experience, but the GHP service is spread pretty thin and covers, I counted it up, I think it's about 630 beds. But I think in the long run it would be important, certainly for the CL fellows, to see this model, to see what work can be like when it's structured this way compared to the traditional model. I think they would like it. I think it would be good for the residents to see it as well. But that's maybe some point down the road. I'd love to have residents.
Thanks,
Nick
Dr. Triplett.
I was intrigued by the finding the home study of the Exeter physicians who were sort of reluctant to discharge people as promptly as other sites. It reminds me of the old adage that all politics are local, that it's hard to change culture. And I just wonder, have you encountered among the units that you have rolled out the service similar inhomogeneities in the responses of attendings?
I'm looking at the other FIPS members. I'll give you my experience, and they'll tell me later I'm wrong. Yeah, I mean, they're different services, and I think it's been really interesting. When we first started this program, the first 3 floors we picked were the house services, the house staff services, right? So there's Longcope, Thayer, and Barker, which, centralized. The residents worked on those units the whole time. Then at some point they said we were post-geography, which meant they were blowing up everything. So the Barker service would have patients pretty much anywhere in the hospital. That had a big impact, I think, on things. For us, maybe not a huge amount, but I think for the culture of the units, it was pretty noticeable. For us, I don't know. I still tell this story, and it's still true. They smile when we're on the units. They know us, right? Because we're embedded there. They're happy to have psychiatry working with them with some of the most challenging cases that they get. So I don't think we've had any exceptions to that on the 8 units that we're covering. You find cultural differences between the house staff services and the hospitalists. The hospitalists are pretty good about turning the crank, getting the patients out pretty fast. So it's a different, similar but different mindset sometimes. But otherwise, I don't think there are huge differences.
Lots of questions, Dr. Ewing.
Okay, Liz, and where's Maureen? Maureen, how many hours was it after starting that we knew the emergency department knew to sort the patients up to the FIPS floors? It was almost immediate. And it's funny, I've talked to people who are doing studies of starting a proactive program, and they want to keep it absolutely pure, no bleeding in other units. That's not how it works. When people talk, house staff cover all these different floors, word gets out really quickly. So we found pretty quickly that patients with psychiatric issues or psychiatric histories were disproportionately showing up on the floors that we were covering.
Which practically, of course, makes a certain amount of sense.
Yeah. No,
Even if it makes, formal study of it a little harder.
It kills the purity of my study, but it's a good practical decision.
Dr. Brandt.
This is sort of along the same line, but I was curious, what are the reasons that you see that the fifth service patients and the unit that the fifth service goes to are primarily majority black as compared to PhD being majority white, and how is that impacting?
That's, we had the same question when we were looking at this. What is it? What is the sorting hat that puts patients in beds doing that we're seeing these differences? And I honestly, I don't know. The early studies where it was, really a head-to-head medicine versus medicine, it was not as pronounced. But when you look at the other parts of the hospital, there are much bigger differences, and I cannot explain that. And I wondered if it's because the house staff services traditionally tend to take Medicare and Medicaid patients maybe more than some of the other services in the hospital. Maybe that's part of what we're seeing, why we see the insurance differences and maybe some of the socioeconomic differences as well, but we really don't know.
Last question, Dr. DePaula.
I was going to say it's kind of interesting that how slowly the administrative structures change. Hospitalist systems were now so ubiquitous, were motivated by the fact that they had a 2-day length of stay change. But of course, a decade and a half later, they realized there's many more readmissions, right? So I think your readmission side is really important. But, the bigger thing is going to be the quality of care. I think you're doing case finding.
No, thank you. That's great. It feels like balloon squeezing, right? You're cutting your length of stay, but all of a sudden readmission rate goes up. You're right. At the end of the day, it's about are the patients getting the care they need.
Yeah. Well, thank you. Great talking.
All right. Thank you.